we have had two topics from our distinguished expert persons. As we are already late, one or two questions from audience, please.
We can ask on the previous topic also, no? Dr. Jayashree, your comments on this myo-inositol thing. I don't know whether you mentioned it to me.
So I said in the beginning itself, I'm not going to address myo-inositol. So therapies which of limited benefit, but interestingly, I think one of the papers that was presented, there was a study done from Madurai Medical College. I think somebody presented a study where they were looking at, it's a small short-term study, and we have to see. In that, it seemed like the metformin with the myo-inositol, a proper placebo-controlled trial, in which, so all of these are very short studies, absolutely no meta-analysis. The way I look at myo-inositol is, it won't hurt, it may help. So if you want to use it, I don't think there is any, it doesn't cause any adverse effects.
Madam, what is the role of eflornithine in the treatment of hirsutism?
I know the skin doctors like to use it. I find it, I don't know, at least from patients who use it, they say as long as they are using it, there is some reduction. But I've not found it to be a permanent effect. So permanent reduction in hirsutism has to be achieved with laser plus medical therapy for a few months. But laser is the only permanent benefit. Eflornithine, once you stop, it will come back.
Excuse me, madam. Thanks for your informative lecture, madam. If I mention about pseudomass, pituitary mass, we have found out in so many patients that TSH, apart from elevated very high TSH level, differentiating points between the real tumor and pseudo tumor clinically and investigation-wise. Because the patient, all the patients need not say other endocrine problems, because they will be coming only for thyroid problem or repeated examination. When they are on failure treatment or they are stopping treatment for a few months or few years, when we are accidentally finding or repeating the thyroid level, it will be more than 150. Those time we are doing the CT that shows mass. How to differentiate clinical mass, that is pseudo mass problem and also the real mass problem. If the patient asks the question, sir, you are saying that mass is there, then whether it's due to real TSH only elevation or due to some other problem, shall we wait for another 6 months or 3 months till the TSH has to come down? Please, ma'am.
Yeah, the message from the slide was, do not refer this patient to the neurosurgeon. The pituitary must be, normally do not image pituitary for a person with severe hypothyroidism. This individual had done his MRI brain because of his constant headaches that he had. He is an IT professional. I told you he also had erectile dysfunction. So he had come with his MRI. So he had severe hypothyroidism, and here because of the severe hypothyroidism and TRH hyperplasia, or pituitary hyperplasia, because of the high TRH levels, the lesion will actually resolve. It will shrink. So here we should not rush to surgery. Treat the person with hypothyroidism and repeat an MRI later. In case of pseudotumor, the mass will vanish. If it is not a pseudotumor, it will remain so. So I think that's the way we differentiate.
Madam, one question for the practitioners. Whether you are ordering the genetic test for all the cases of azoospermia, ma'am?
Non-obstructive cases. But even in some obstructive cases, microdeletions have been documented. So any azoospermia, yes.
We have to go for genetic tests. And what is your opinion about the DNA fragmentation index?
Ma'am, I'm not a reproductive medicine specialist. I'm a general endocrinologist. But I think if there is a higher DNA fragmentation index, the fertility issue, then they have to go for donor sperm program.
So what is the dose when you are treating the hypogonadotrophic hypogonadism, the FSH and LH doses, ma'am? You told that,
if you have a good testicular volume, we can start with HCG therapy. HCG is like a long-acting LH analog. We start with 2,000 units thrice a week, and then we have to repeat their testosterone levels in 8 weeks' time. Semen analysis also has to be repeated often, every 3 months, and if the testosterone levels are not getting elevated with 2,000 thrice a week, we step up the dose. We can go up to 10,000 units, and even higher doses as 10,000 thrice a week.
If still not getting up,
no, we have to add HMG.
HMG.
Yes. So we wait for at least 6 months. Okay. But if they have a lower volume of testis, it's better to start with the dual therapy. HMG started as 75 IU thrice a week, stepped up to 150 IU thrice a week. So you can give it combined along with HCG in patients with lower testicular volumes. And that will, they say that spermatogenesis occurs a little earlier compared to HCG therapy, monotherapy alone.
So only when the testosterone level is low, you will be going for the testosterone treatment.
Yes.
So the basic is for the rebound phenomena to occur.
Yeah, so if somebody is desiring fertility or paternity, we should not offer them testosterone. Straight away go for HCG therapy because of the cost factor. Testosterone replacement treats androgen deficiency and it's a cheaper and a convenient way. We have to give only once in 4 weeks. So we give intramuscular depot preparations, testosterone and then theta or cypionate. We give adult doses 250 milligrams every 4 weeks or every third week. So that is given for men for androgen deficiency. But the moment they get married and paternity is desired, switch over to HCG. Because HCG is very expensive, HMG is even more expensive. So HCG monotherapy can be started off for men with reasonable testicular volumes, and if response is not seen, then we can add FSH or HMG.
When we are seeing azoospermia case, first you go for the ultrasound, you look for volume, then we have to proceed.
Yeah, we have to differentiate between obstructive cause
Obstructive and
because the treatment
non-obstructive.
is totally different.
Okay.
And endocrinologists don't have much role in azoospermia.
Okay, madam.
Except in cases of hyperprolactinemia. As I mentioned earlier, man
Yeah,
with
erectile
macroprolactinemia,
dysfunction.
he had azoospermia because of high prolactin. There again we offered HCG therapy because he had reasonably good testicular volumes. We gave him cabergoline as well as HCG and spermatogenesis. Now he is a father of a child.
Thank you very much, madam. Madam, one question from Jayashree, madam. Before starting metformin, routinely you will be going for HbA1c level.
Yes,
Madam?
very definitely.
Okay. What's the preconceptional level of the HbA1c you will be advising, madam?
Usually less than 7, if possible less than 6.5 is ideal.
Preconceptional means it's it must be around 5.8, no, madam, or it's okay when it is.
You mean
around
planning for a pregnancy, right?
Yeah,
So
yeah,
if they're non-diabetic, in general, if it's 6.5 or 7 and less, that will be safe enough for a good pregnancy.
Thank you, madam. Thank you. Thank you very much.
May I comment?
Sorry, sir.
Regarding that last point on that hypo treatment, there was a nice paper from KEM Bombay. I think Anjali would be definitely aware of that. They have done on straight away starting with HMG, HCG when they are diagnosed at 17, 18 years. The traditional conventional thing is what we are all following till today, and it works well. And
It
most
is
of the
only
guidelines
because of the
mention.
cost factor. HMG is
What
very
they are
expensive.
saying is just like how you start in a type 1 diabetic, you start on insulin. Here there is a deficiency of the gonadotropins. You give gonadotropins right from word go, pubertal induction, and many of them respond well. And once they start spermatogenesis, preserve the sperm. Then go back to testosterone therapy and you may use it later.
But that will not prevent the azoospermia. Again, the
Yeah,
spermatogenesis
it's not
is
like you are restoring fertility naturally,
Yeah,
but the response of that is seemingly better than a patient who has been on testo for more than 10 years. He comes at the age of 30, 32 for therapy. Yeah.
Thank you, madam. Thank you, organizers, for this.
Thank you very much for that session. So sorry for the technical glitch. So I think we will move on to the next session. But before that, can I request Dr. Muthukumaran to felicitate our chairpersons and speakers?